So we're going to be talking about upper tract TCC. And before I get started, I just want to mention that today's a very big day. The 2008 playoffs get started. Flames are kicking it off against Detroit. And I think there are a couple other Canadian teams in the playoffs, but I don't think anyone's really given them a chance. So I broke the talk up today into three parts. I'll talk about some the natural history and prognostic factors of upper tract TCC. We'll then move on and talk about some issues in diagnosis, mainly the role of endoscopy. And then we'll move on to management issues, talk about lap nephroureterectomy and nephron-sparing and endoscopic approaches to management, and hopefully stimulate some discussion, so feel free to fire in if you want to. I'd like to just preface the talk by showing this slide of levels of evidence. Because this is a rare disease, it's difficult to accrue patients for randomized clinical trials, so most of the evidence for the things that I'm going to talk about comes from either level 2 or lower or lower types of studies, mostly case series, some case controls. So upper tract TCC is fairly rare. It comprises 5% of all renal tumors and 5% of all urothelial tumors. It's more common in the Balkan region. Its epidemiology is similar to that of bladder TCC, and risk factors are also the same, as fairly similar to bladder TCC, aside from analgesic nephropathy and some endemic diseases such as Blackfoot disease and Balkan nephropathy. So previous bladder cancer is quite common in people with upper tract tumors. Up to 80% of upper tract TCC is preceded by bladder cancer. There's a 2 to 4% incidence of metachronous upper tract TCC in patients with superficial bladder cancer. This usually occurs over 5 years out, and it's known that this incidence increases with time. Some risk factors have been delineated for metachronous upper tract tumors. CIS, and particularly BCG refractory CIS, represents a very high risk group. And so based on this, the recommendations for upper tract screening in patients with bladder cancer as follows. Regular imaging is recommended for high-risk patients, so those with any high-grade bladder tumor, CIS, or invasive pathology should get annual upper tract imaging for at least yearly for at least 2 years, and then you can increase the interval. But they should be imaged long-term as their risk increases with time.
What's the logical stretching out the imaging? What's the logical stretch out the imaging interval? I think you said 70 months to develop an upper tract TCC. Why start stretching out? It seems to be seeing the higher risk period.
I'm not sure if a lot of this is just seems not to be based on any trials or anything, but I think the point is that you should screen them long term. I don't know why you'd want to increase your interval, but.
Just a quick show of hands, how many people screen that get bladder TCCs upper tracts on an annual basis?
Everyone or just high grade?
All patients. Significant tumors will be full. Any high upper tracts or just bladder? Upper tract.
And it's not really, and the best modality isn't really delineated. We don't know what's best. Should they just have ultrasound? Should they have CT-IVP? Should they have retrogrades? Does anyone have any comments on what modality they like to use, or just an ultrasound? So 2 centimeters is.
Yeah, if you know it's there already from retrograde, you'll pick it up over half a centimeter, 5 millimeters, whatever. But if you don't know it's there already, you'll ignore everything under 2 centimeters.
So it's a waste of time to screen.
If 2 centimeters, plus it's more than 2, if the 2 around that range, that would look for you. How do you find the comparing CTIVP, conventional IVP, Okay, yeah, we'll talk about that.
So it's been shown that patients with metachronous upper tract tumors do better than those with primary upper tract TCC, but I think that's probably a detection bias. These patients are usually on surveillance, so they're picked up earlier. So for primary upper tract TCC, this is a more invasive disease than bladder TCC. There's a 40% higher invasion rate. It's been estimated that over half of these tumors are invasive when they present. Up to 20% can present with metastatic disease. The propensity to invade is explained by the smooth muscularis seen in the ureter and renal pelvis. And in the renal pelvis, there's actually a parenchyma that can act as a barrier to further invasion. So recurrence is common after treatment of upper tract TCC. There's a fairly high local recurrence rate, and the theories of recurrence are either based on the field change disease of the urothelium or distal seeding. The most common site of recurrence is in the bladder, and it has up to 75% incidence. And these happen fairly early, and so this highlights the need for bladder surveillance in patients that are being treated for upper tract tumors. The prognosis for upper tract TCC is very much stage dependent. This is basically a summary of all the Open Nephrectomy series, and you can see that non-invasive disease carries a pretty good prognosis, and it goes down from there. This is confirmed by the SEER database that showed similar results for in situ, local, regional, and distant disease at 5 years. Now, location is a fairly important prognostic factor as well. The renal pelvis comprises the location of the majority of these tumors. The remainder in the ureter, and they increase as you move down the ureter. This group from Korea tried to compare ureteric and renal pelvic tumors. They looked at pathologic characteristics, and one thing they found was that ureteric tumors were more likely to be invasive and high stage. And this translated into a survival difference. At about 5 years, there was 30% difference in survival. And so again, the renal pelvis may have a better prognosis because you have the renal parenchyma there that acts as a barrier to further spread. Other factors include sex and race. Females and African Americans tend to do worse for whatever reason. Histologic factors, lymphovascular invasion carries a poor prognostic. Dr. Wilmer?
You keep referring to the parenchyma as a barrier, but the pelvis surrounding is a lot more lymphatics and blood vessels in the ureter. Would that not factor in theoretically?
Yeah, theoretically, yeah, sure. But I don't know how else you explain the better survival for renal pelvic tumors.
Stage for stage, is there a difference? Do you match stages?
That's a good question. I'm not sure. As in the last previous study that I showed, the ureteric tumors were more likely to be high stage, and that's probably what explained the lower survival. But just the fact that ureteric tumors are more likely to be invasive is.
I guess the point is that on a molecular basis, are they same tumors? Histologically, they may look like TCC, but are behaviorally are they the same?
Not sure.
Many different microcytome analyses and also X-linked design back to see which X chromosome is suppressed to see whether or not it's clonal versus multiple. And the results are always like one paper will show clonal. But that being said, I don't think there's any evidence to show that the ureteric tumors are genotypically worse. I think the phenotypic difference that you see here are secondary to other ways. Like those who think that tumors in the pelvis are
Easy to pick up. Yeah. Right. Okay, so it may not be, the survival difference may not be a product of the actual tumor biology itself. So we'll move on from background to discuss some issues in diagnosis of upper tract tumors. Most patients present with hematuria, either microscopic or gross, and as such they'll undergo the following investigations, most of the following investigations. Cytology for upper tract tumors is kind of the same goes for cytology for bladder tumors. Sensitivity is related to tumor grade. False positives are basically anything that causes inflammation or infection. The method for getting upper tract cytology, the most sensitive method is barbotage or washings, and this is because it supposedly releases loosely adherent malignant cells, and so you're most likely to get a positive result. And the significance of isolated positive cytology without a radiologic finding or an endoscopic finding is a bit of a controversial issue. Is that considered upper tract CIS? Is it something that you just watch? Anyone have anything to say about isolated upper tract cytology, how they treat it, or whether they just survey it?
It's always a dilemma. I'm never going to take like that. Do we agree with the course in which we have positive psychology but no evidence of disease? And everyone you talk to agrees that you never treat upper tract disease without localization from where the tumor is. Even though the other disease can be involved in that.
Mm-hmm.
So I think what you have to do is try to localize whichever you can do very carefully. But that can be done, especially if you're bladder biopsy, or urethral bladder biopsy. And you have to, if anything, do nothing to leave, and explore what's not for you.
Okay. Anyone doing upper tract BCG or topical therapies? Okay. So IVP is sort of historic interest nowadays. It's been mostly replaced by CT IVP, which has a very high sensitivity for upper tract lesions.
Perhaps Ryan or Ben can comment, or William probably had a lot of experience with this as well. What about ureteroscopy?
Yeah, we're going to get into ureteroscopy.
Yeah, positive psychology. I don't know, not that long ago, ureteroscopy, the visualization was probably good enough to tell we need from all ureteric, but I don't know, today the visualization is actually not much better.
The new ureteroscopes with the chip on the tip is going to open it up to a new domain where we'll be able to visualize every case and probably the most sensitive way of diagnosis.
Yeah, we'll get into ureteroscopy in a minute there, and we can discuss CIS as well. The sensitivity, so CT IVP is quite sensitive. Specificity is only around 60%. In predicting stage, it's again only about 60% accurate. It's easier to perform than an IVP, which is an advantage. Yeah.
I disagree with that last statement because I think false positive for psychology is so high. I mean, you got these so-called non-strict psychology. Too many people are already having these ureteroscopies and they heck of a lot more. So I think we've got a tool that we really have to be very, very careful with. I personally not really so something with positive psychology. That's us.
Suggestive features on CT-IVP include filling defect, non-visualization of part of the collecting system or ureter. Hydronephrosis has been associated with invasive disease in up to 80% in one series. And the usual tissue density of a tumor is between 10 and 70 Hansfield units. Enhancement isn't a necessary criteria. So this is an example of a lesion in the left renal pelvis. It's got kind of soft tissue density. Doesn't look like it's enhancing it. Basically providing a filling defect in left renal pelvis. Retrograde pylography may be useful in further characterizing equivocal filling defects on CT. Should I?
Post-CT versus your historically conventional.
Oh, I think CT is a lot better now. The IVP was so hit and miss on how one got the best, how one got the same, and such a variable, but I think CT is twice the treatment as good as we do all CT IVPs now. And I think CT IVPs, as long as you do a classification, which you do virtually all the time, is very, very good. I don't think you're going to miss patients over 5 millimeters at all, unless they're just a CIS or flat-back thing. I think you're going to come out beautiful as long as you do a classification.
Does the
station at the same time, contrast study, so you can see those in the same extension. That will stay working on.
Does the same go for MR urography in patients with renal failure?
Now, we used to talk about the today's approach, MR was not as good, but I think nowadays computer magnets are really good. It's just access issues. As long as you get access to CT, keep it this MR.
And is CT a feasible thing to do in surveying patients? Are we doing it every 3 or 6 months?
And I think the radiation risk, the CT IVP is a fairly high dose procedure.
Yeah.
But I think most of the patients are 60 or older. And I think, you're looking at 20 years out developing lymphomas of radiation risk. So if you're looking at patients over 60, you're really probably okay to survey people once because of the I think if you're looking at 35-year-olds develop everywhere else, then they have solutions.
Okay. Dr. Masterson?
Wouldn't an MRI be disadvantaged in terms of differential radius slow?
Well, you see the signal effect. The elements you get more experience with that.
Yeah, it's small sense to me, right?
It'd be difficult to pick up, but there are those signals. But if you do see them, you don't. Then you have to work them up further, so you actually carry on with them. But those are the ones you scope. Go have a look at it. You have uroscopy, etc. to see what it is. They're good. The diagnostic. You can see them. So I'll show you this in the legend. So not what they are.
Okay. So retrograde may add a bit for equivocal lesions on a CT or MRI, and it's often combined with ureteroscopy for these equivocal lesions in the workup of a filling defect, say. So ureteroscopy has been shown to increase the diagnostic accuracy of cross-sectional imagery up to 85-90%. It's said to be the gold standard for evaluating filling defects and obstructive lesions of the upper tract. The technical points are basically if you're going to take cytology, take washings before you biopsy suspicious lesions. If you're instrumenting and manipulating them, may alter your cytology result. But I think obviously the tissue is going to be the more important thing there. And basically, if you have a papillary tumor, you try and pull off the papillary portion and then ablate the base. We'll talk about the different options for tissue sampling. And you don't have to go deep, you don't have to get muscle like you do in the bladder. Basically, the grade of the tumor has been shown to correlate with stage, so you don't need to necessarily get through all the layers. And usually a stent is left in place. If you have a patient with previous cystectomy, antegrade placement of stents or wires will help you get up into the ureters. So there's basically 3 ways to get tissue ureteroscopically. There's grasping the tissue, the papillary portion of the tumor with a basket. If you're using a rigid scope, you can resect, or you can lase the tumor off and then ablate the base. And again, grade correlates with stage, so you don't have to get a deep bite. It's been shown that grade 1 or 2 lesions are most of the time non-invasive, while grade 3 lesions are about 2/3 of the time invasive. And it's been shown that the ureteroscopic grade correlates with the pathologic or the surgical grade in about 80 to 90% of cases. So the grade that you're getting on your ureteroscopic biopsy is fairly, you can stand by that. The question is do you even need a sample tissue at all? If you see the tumor, is that enough to convict? Arthur Smith and a group looked at that, and they basically found that for what they thought were low-grade tumors, they were wrong about 30% of the time. But the pathology ended up showing grade 3 tumors for what they thought was a low-grade papillary tumor. So bottom line is you do need tissue. Looking at it's not enough, especially when you have a few treatment options, which we'll talk about. Ureteroscopy has been deemed to be safe. The question is in the setting of malignancy, can you facilitate malignant spread either through pilovenous, tubular, lymphatic backflow? There's just a retrospective series looking at 96 patients who eventually had an open nephro-U. Half of them had ureteroscopy in their workup. The groups were similar in terms of demographic and tumor features over 4-year follow-up, and there was no significant survival difference. Again, not high-level evidence, but controlling for everything but ureteroscopy and comparing the groups with ureteroscopy to no ureteroscopy, there's no difference. So I'll put this back out to the audience. Then, should everyone have ureteroscopy, or are some people with a history and filling and suggestive radiologic findings good enough to go to the OR? So this, for an example, this is a 66-year-old male who's an ex-smoker, normal renal function, presents with persistent microhematuria. He's got positive cytology. Bladder is negative for any tumor, and he's got a lesion on the CT-IVP in the left collecting system. There's some filling defect. Is there anyone that would not characterize that further and go for some sort of treatment, or would everyone do ureteroscopy to see what that is, or any? Start with the retrograde.
And if I see a filling defect, I'm referred to filling defect or positive cytology.
And you'd go ahead if they had normal renal function or whatever, you'd go ahead with the nephro-U kind of thing. And you wouldn't need. So for you tissue, you don't need it basically.
You have two studies that confirm the same thing: filling defect, not spelling positive cytology.
And if cytology was negative, would you still say? Okay. Say he had full on cystoscopy, and sure, he had biopsies too.
The CT shows it's not a stone, and the CT shows it's a defect. You just don't know whether it's a clot or a tumor. So if you're going to do retrograde, you're still not going to know whether it's a clot or a tumor. What happens to retrograde and helping him? Unless you put a scope up there.
He's only had micro. He's never.
Doesn't tell you whether that's a clot or not.
Marty, what would you do?
That's Dr. Sullivan.
Well, I wouldn't do it.
That's Dr. Sullivan.
I wouldn't do anything, Marty, because I don't have a license anymore. Well, then I would have a look at it with a scope and get a biopsy with that.
The other thing too is we're all creating with the other bladder and if we not that but both and also becoming
So other molecular markers then that can aid in diagnosis.
If you're worried about this, I think everyone knows that this was malignant. But if you are concerned, there are other ways around it rather than looking at it.
So who should have ureteroscopy if you're unsure if they have a radiographic lesion, you're not sure, you want to confirm. I think especially if you're going to perform some sort of nephron sparing management. If you're going to manage them endoscopically, then you want to get tissue and know what you're dealing with. And ureteroscopy in the workup of positive cytology, no lesion, we sort of discussed it's kind of a 50-50 whether you do it or not.
So you're saying everybody, your first point says everybody.
No, I'm not saying. I'm just saying these are some reasons why people might do it. I don't think everyone with a lesion should have ureteroscopy. Because you could reason.
Size of the lesion matters too. If you're a small little lesion that you may want to repeat, see that you must not believe it, and see if it changes. If you have a large lesion, it's obvious. You don't waste your time doing the ureteroscopy. You're just going to go ahead.
What's your cutoff, Mark? Size?
Just show. But I have to look at it. I would take a centimeter or so to be cut off. Positive cytology with no lesion. I mean, there's a little controversy here before. I think as ureteroscopy gets better, 10 to 2 feet from the ureteroscopy, that picture that you showed before a few slides ago, I mean, what can you get? That's a terrible image. That's what ureteroscopy looks like now.
Yeah, that's not doing it justice, but yeah.
If you get a clear image like you do now with William referred to the chip on the tip scopes, and you see the bladder so well through the flexible scope, if we get that same image in the upper tract, I would be more inclined to have a little small flexible scope, but almost do it if they're under local anesthetic. For a person who's not as skilled as Ben or Ryan, what if I looked in and I didn't see anything? I mean, I looked and I wasn't sure. Well, why don't we keep this thing going? Why don't we put it in the prostate tube?
Change eyes.
Yeah, change it. So I mean, why don't we go to the next step? Put it in the prostate. We're going to keep putting scopes everywhere. Where do you stop?
Mm-hmm. Yeah. How far do you go looking? Which brings us to our next. So, this is mainly it can be diagnostic and therapeutic. The percutaneous approach. It's mainly for large renal pelvic tumors. The advantages are larger instruments. You can take a better biopsy, and you can also leave a tube. And if you want to explore any topical or chemotherapies, you can. It's better to go through the percutaneous route. The disadvantages are obviously the morbidity, and there have been reported cases of tract seeding. I won't get into it too much. We'll talk about some of the results of endoscopically managed patients with upper tract tumors. So we'll move into management. The options range now from nephron-sparing approaches to radical approaches and adjuvant treatments with topical and chemotherapeutic agents. And basically, the therapy should be customized to the patient based on comorbidities, renal status, their anatomy, and tumor factors. If you have someone you've confirmed that they have upper tract TCC, you weigh the risks of tumor progression versus, especially if you're considering nephroureterectomy, the risks of them being on dialysis, and obviously the surgical risk. Can they even have an operation to begin with? And just looking at the dialysis point, the median the median survival for all patients on dialysis is about 5 years. That's everyone. So that's and so if you look at invasive tumors, they're more likely to die of their disease than to die of dialysis. They're more likely to, if you cut for the invasive tumors, they're more likely to die of recurrent disease than of dialysis complications. So they're probably better served getting everything out and being on dialysis. That's one argument. Anyone have any comment or?
I'm not sure that the surgeons are correct. I mean, the reality of it, the difference in survival rates, just for me, aren't that great. 5 years of hemodialysis versus taking a chance. That's exactly what stage you're talking here. But for surgeons, it's not as easy to take all of them in hemodialysis for 5 years. But as a patient, I'm not sure that's quality of life.
Well, yeah, it's it's all kind of weighing risks, and are you more likely to die of the tumor, or are you more likely to die of a dialysis complication? And you got to kind of think of that, I guess. And I think it's fairly clear cut for invasive tumors that they're likely to die of a cancer death. This is based on open nephroureterectomy data.
This is nephroureterectomy?
Yeah, nephroureterectomy. No, this is nephro-U. So, sorry, the title of the slide should be just management decision versus dialysis. Yeah. So the open nephroureterectomy has been the gold standard. It's mainly indicated for invasive, large, high-grade upper tract tumors. Decisions you have to make are whether you're going to do it through 1 or 2 incisions. Lymphadenectomy is usually done if it's easy, although no therapeutic benefit has been shown. And then the technique, you need to get a bladder cuff. We know that there's up to 60 or so % incidence of recurrence in the retained stump if you leave anything behind. So this is an example of flank plus toric position, and this is an extended flank incision, doing it through a 1-incision approach. There are other approaches. You can do everything through one big midline. You can combine a flank and a Gibson, or a subcostal and a Gibson. Either way. So again, the cuff is of utmost importance. There's a few ways to get a cuff. These can be basically open or combined open and endoscopic. What's regarded as probably the most surefire way of getting a good cuff is doing a combined transvesical, extravesical maneuver. You make an anterior cystotomy, 1 centimeter circumscribing incision around the UO, dissect right out into the extravesical fat, and basically dismember the ureter with the cuff of bladder there, and close the bladder in 2 layers. Again, the role of lymphadenectomy is controversial. There's been no shown therapeutic benefit, but it may add prognostic information, and you can consider patients for adjuvant therapy, although, again, no benefit for adjuvant therapy is even shown in these patients. So basically say do it if it's easy and if it's not going to add too much OR time. So again, you've seen the slide a few times, the results of, this is the combined results of open nephroureterectomy series. Lap nephroureterectomy, yes?
I think the open nephrou is historical. I think in a lot of times, I think the first choice is the lap upper kidney, either open or lap or bottom. I think the down is the gold standard. Is historical English. I think if you don't offer your patient a lap, practically there's some way to hang it lower.
Yeah, I think referring to the open nephroureterectomy as a gold standard it's pretty much.
Just go back to the bladder cuff question.
Yeah.
And historically, the reason taking bladder cuff is there's a higher risk of local recurrence in the bladder. If we take a cuff and move the entire ureter is different than the stump ureter and the cuff and bladders. Is that gone by design and just pull the ureter out, retrograde, whatever, is that adequate? And we would set the historic standard of taking cuff because that increases security or recurrence.
Yeah. Well, there's going to be when we talk about lap nephroureterectomy, there's one study that compared a couple different types of taking the cuff that we can talk about. But basically, the importance of taking the whole ureter in a cuff is based on the fact that the recurrence in the retained stump is quite high. But bladder recurrence remains at 20 or 30 or more percent.
Taking the stump is different than taking the stump plus a cuff of bladder.
Yeah. Right. Well, I think you need to include. I think you need to take a cuff of bladder with your stump. Yeah, definitely. And there are a couple of ways of doing that. So the lap nephro is destined to become the new gold standard. The follow-up is just too short-term at the moment. But the advantages are decreased morbidity, and disadvantages include port site recurrence, which has been reported in a few cases. So basically, the nephrectomy is performed in a similar fashion as for a radical nephrectomy. The colon's reflected, ureter and gonadal vessels are identified in the retroperitoneum and marched up towards the hilum, which is controlled in a similar fashion. Ryan or Ben, do you have is there any difference to the nephrectomy portion of the operation than for a radical?
I think it depends where the tumor is located. For rural tumors, and it's high grade, then you assume it's high stage, and it's often significant hyperprosis. And so you can have a case in which you have a distal rural tumor, and you've got significant height, and you have to be very careful not to have the hypoponic tissue rupture during the laparoscopic portion of the operation. For tumors that are up in the renal pelvis, you have an early control of the ureter. As soon as we identify the ureter, we clip it. We don't want, with the manipulation of the kidney tumor cells, moving downstream with potential for, at least theoretical risk of seeding of the bladder. The renal pelvic tumors and upper rectal tumors, there's often significant inflammation around the kidney. It's a very different dissection than a radical for a renal cell carcinoma, and so I think it's a tricky operation, and have to be very careful, and specifically in the setting of nodal disease, which may be understaged from the preoperative CT. And then the other issue is with Metachronous Bladder TCC, and then you'll be discussing that. But the issue is this is not a large volume procedure. Like I've done about 30 of these in 3 years, and it's just not a large volume. Now that I've moved on to doing the guilt technique of basically endoscopic procedure to deal with the distal cuff, and so I've always approached it through an open incision and dealt with it through Gibson and with a repositioning technique. And the extravesical approach to try and get that upper bladder is tough sledding, specifically in, I think, in an obese patient.
So we'll just get right in. Oh, sorry, Dr. Chin. So this is the guilt technique that they're referring to. It involves putting in these two needlescopic ports into the bladder and a resectoscope, which everyone, of course, does, no problem. An endo loop is placed around the distal ureter as it's circumscribed with a Collins knife, and the endo loop is fastened to prevent any spillage. You take your 1 or 2 centimeter cuff with the Collins knife, and then you just keep dissecting into fat and eventually dismember the ureter and pass it back into the retroperitoneum. And the defect isn't closed. They leave a catheter in there for a couple weeks to do a cystogram. I don't know how people feel about that, but the other technique is this also combines endoscopic and this is the total laparoscopic way of taking the cuff. This is the extravesical stapling. Before the patient is positioned for the laparoscopic portion of the case, cystoscopy is performed. Resectoscope is used to fulgurate the UO and dissect and take a cuff endoscopically and dissect out the intramural ureter and kind of mobilize it somewhat so that it can be pulled back, and then a stapler is fired. So if you're gonna make a decision to take the kidney out, why not just open anyways and do a good cuff. Gill looked at compared to the Gill technique to the Extravesical stapling it doesn't say here how many patients. 60 patients. It was about 2-year follow-up, and the stapling had a higher positive margin rate and higher bladder recurrence rate than the Gill technique. Neither of these were compared to open. So again, recurrence is quite common in these people, bladder being the most common site, and so surveillance is close surveillance is of the utmost importance. Cytology and cystoscopy every few months for a couple of years, and then broaden it out. And upper tract imaging is obviously important as well, although metachronous contralateral tumors are fairly rare. This is a summary of Laparoscopic Nephroureterectomy series. And basically, we have 2-year survival data, and it's comparable to Open Nephro-U. And so it looks like basically, survival and cancer control is equivalent at about 2 years. One of these studies I'll just pull out. It's the biggest study comparing 224 patients, 58 of which had a lap nephro-U. All of these patients had an open cuff excision, and basically oncologic results were similar. Again, you see a lot of patients get bladder recurrence. There was one port site met in the lap group, and the overall survival was about the same at 28 months. Looking at operation convalescence data, OR time in a lot of the early series is quite a bit higher. However, length of stay and complication rates have been shown to be lower in quite a few series. I think it's changed a lot. I think the learning curve is this is pretty that's pretty old.
Are they still learning on the open side 4 hours?
Yeah. They weren't trained at UBC.
That's children. Is that children's hospital?
Yeah. So the bottom line is that lap nephro-U appears to provide similar oncologic results in the short to intermediate term, and it's a less morbid option, and it's probably going to become the gold standard. So nephron-sparing approaches, these include endoscopic and open approaches, such as segmental ureterectomy. These are best for kind of lower grade, lower stage, smaller tumors. Absolute indications for nephron-sparing and are above. Relative indications include people with high risk of recurrence, all those Balkan nephropathy patients that you see. And basically the options are, again, endoscopic or open, and the open options basically depend on where you are in the system. And basically the endoscopic approaches, again, for smaller low-grade solitary lesions that are easy to get to, and ideally in patients that can't handle an open operation or a laparoscopic operation. And open nephron-sparing surgery, such as segmental ureterectomy, is best for patients that definitely need nephron-sparing, distal ureteric tumors, or tumors that are too big or to get endoscopically. The follow-up for endoscopically managed patients is a bit more stringent than those that are managed with radical surgery. They need a bit more frequent cystoscopy and cytology and upper tract imaging. Get a retrograde if there's an equivocal finding, and repeat endoscopic evaluation for any positive cytology or radiographic findings. So this is a summary of patients that were managed percutaneously for renal pelvic tumors. You can see that most of of the patients had lower grade disease. So this is the percentage of grade 3 disease. Recurrence, ipsilateral recurrence is quite common, and almost a quarter, if not more, eventually went on to get a nephroureterectomy, either for progression or recurrences. And survival was quite good here. But again, a lot of these go on to get nephroureterectomies. They don't kind of futz around with high-grade disease if they can handle an operation.
An important question, though, is the patients who had a recurrence and then went on to secondary nephrectomy. Those are the survival patients between those who just went on, just had primary.
It's a good question. I don't know if I didn't see that graph in the studies.
Another comment too quickly. I think the days of the retrograde diagram are just not days of this, days of the IDP. I think that if you've got a questionable lesion, I don't think the retrograde is going to tell you the answer in both cases, especially those that are generally done without related neurology. So it's another issue. But I think you're in it. I think we're seeing this at a time that same way the CT-IVP is replacing the IVP. I think if you've got a questionable lesion, you've got to do a retrograde, uroscopy with contrast. Uroscopy with contrast to make sure you're seeing all the Biopsy, seeing they're in there. Something great thing on the retrograde. Your uroscopy with marble is what you really want to do. I think that just doing a retrograde contrast that is marginal for treating prognosis or to differentiate what you do want. So I think that it's coming to an end.
Anyone? No? Ureteroscopically managed patients have similar results. Sorry, the font is not big here, but recurrences, local recurrences in the upper tract, common. Number going on to nephro-U, and survival data are about the same. Just a quick slide about topical therapy. This would be BCG. There are a few series out there that basically include patients with persistent positive upper tract cytology, no endoscopic findings, no radiologic findings, and they call them upper tract CIS. And they give them BCG or mitomycin or thiotep or whatever through a few different ways, either through a perc tube or through bladder installation with a double J stent that allows reflux. And these are all fairly small studies, short term, not controlled, and so there's no real established role. Any comments? Anyone have any experience with it? So the bottom line for nephron sparing or mainly endoscopic approaches is that you have to accept that recurrence is going to be a common thing. You need to survey them quite stringently. There's a high likelihood for repeat treatments, either endoscopic or moving on to radical surgery if they're a good operative candidate. And basically the outcome, as in this disease in general, is grade and stage dependent. And so it looks like endoscopic management is feasible for low-grade focal tumors, and especially if they're poor operative risk. Dr. McLaughlin?
Another option I did a couple years ago was laparoscopically mobilized out the ureter. And I brought the ureter out through a small incision, took the tumor out, gave anastomosis, and dropped it back in.
It's like a lap-assisted segmental ureterectomy.
Yeah, just took it out through the extracted, and it was the hands and just brought out. And historically, way back when, for nephron sparing, we did the bench surgery. We take the kidney out, take the tumor out, and then take the kidney back in after. So it's, I think it just keeps it going. But I think with the technology, you just have to keep using your brain to modify it.
So treatment of metastatic disease, again, this is fairly rare. So there's no big clinical trial, but from what I understand, these patients are given the same systemic therapies as metastatic bladder cancer. You get MVAC or gemcitabine cisplatin, and the results are, there's no good evidence for this. So in summary, upper tract TCC is rare. Invasion of Mets are common. Ureteroscopy adds diagnostic accuracy and is considered kind of the gold standard for evaluating an equivocal filling defect. And it can help plan management by getting tissue and defining grade and stage of the lesion. And management is basically tapered to the patient and pathology characteristics. Lap nephro use seems to be a good option in the short to interim term. Endoscopic approach is feasible for low-grade tumors and people with poor operative risk. You need to accept that recurrence is common and need for multiple treatments. And surveillance is a must.